Hello and welcome to the Johns Hopkins University Biomedical Informatics and Data Science Grand Rounds. I'm Paul Naji. It's really a pleasure to have you here today. It is my pleasure to have our Grand Round speaker, Dr. Khyzer Aziz. Khyzer serves as an associate professor here at the Johns Hopkins School of Medicine and serves as a neonatologist and clinical informatician here. In addition to caring for some of the most fragile newborns, he works at the intersection of medicine and technology, exploring how data and informatics can be used to improve the outcomes for infants and their families. He serves as our Chief Medical Information Officer for the Johns Hopkins Hospital, where his focus is on building bridges between clinicians, researchers, and IT teams to make technology better for patient care. He also serves and directs the Neonatal Precision Medicine Center of Excellence and helps train future informatics leaders through the Biomedical Informatics and Data Science program. He serves us as our associate director of our program. His work is guided by a simple goal to use data and innovation to ease the burden on providers and bring better care to the bedside. It's really a pleasure to have you. Khyzer is a very close colleague of ours and a key leader within our informatics community. Khyzer, thank you again for coming today.
Thank you so much, Paul, for the incredibly kind introduction and the opportunity to speak here today. I'm going to start sharing my screen. Hopefully it's coming across. I'll take all your thumbs up as a yes, it's coming across. Nice. Okay. So I think we went through these slides already. I don't have any disclosures at this point. These are the objectives. You saw these scroll through in terms of the things that we'll be talking about, but really the intent is to convey how we've been doing things here locally in our BIDS program. In terms of our overview, apologies, the slides seem to be lagging a little bit. So we'll be talking about, I'll give a background and definitions, that way we're all speaking the same language, talking about some of the same things. I'll try to provide examples of the things that we've been doing here locally at JHH, and in terms of some of the multimodal data work, and the term multimodal is being used loosely here. And then I'd really like to focus on what we're doing, what we're trying to do, what we'd like to do in the next few years, but really with technology advancing so quickly, things we were hoping to do in a few years, we're probably going to be able to do them in the next couple of months. And one of the unstated goals really here today is I'd like to highlight the Biomedical Informatics and Data Science program here at Hopkins. And I'm going to show you what some of our students have been doing here, master's and PhD students, and the different projects, the different opportunities that they have locally here at Hopkins. I'm going to start off with this slide because one of the things our lab studies and some of the work that I do as part of the Precision Medicine Center of Excellence is we study brain injury in preterm infants. I'll use this pointer to make sure. So brain injury in itself can be due to multiple organ systems, different interventions that are happening within the hospital itself. It could be related to environment, right? Environment before a baby's born, environment after a baby is born. And then also timing of insult. Hopefully this is coming through, right? And this timing, is it the time right before a baby's born? That's something. Is it timing of injury relative to right after a baby's born that results in brain injury? Or does it depend on during those first couple of years of life where it's due to invasive therapies that are being provided in the NICU? They have different interventions that are happening. Or is it a function of the entirety of a person's life, right? Because brain injury could be impacted not only by what happened in the NICU, but what's your life course? What's your longitudinal trajectory? And this complexity of involving multiple systems, multiple interventions, and the aspect of time, it's not really just unique to brain injury. This is applicable to numerous disease states and use cases across specialties. For example, my colleagues who are studying Alzheimer's, my colleagues who study liver disease, cancer, asthma, COPD, they all run into this complexity of incorporating multimodal data, multiple factors, and time to understand disease progression and disease recovery. Locally here at Hopkins, we've been investing and building these data pipelines for the better part of a decade now. And with these data pipelines, right, we have the In-Health Precision Medicine Initiative, which was launched by some of the folks on this call right now, leaders in the room on related to let's set up Hopkins to succeed. And Dr. Rosen was involved, Dr. Ziegler, Dr. Shute, Dr. Naji here, where let's build these pipelines. They're a decade old. They're starting to show their age, but the intent is to go ahead and keep building them, making them more robust and future-proofing them. And this is where some of the new emerging technologies are helping. We also have built data pipelines through the OMOP Common Data Model, which is work led by Paul Naji and others. And I think the Odyssey conference is today, so I know I'm sad to be missing it. A lot of our collaborators are up in New Jersey right now for the annual conference. But overall, everyone's working together to build these data pipelines because regardless of your question, your specialty, your case of interest, we all need data by disease state. We need data by medication. We need it by intervention. And importantly, it needs to be longitudinal data captured as a function of time, which we can actually turn back and use for translational care, clinical care. So when we started out back in, I've been at Hopkins since 2017. And back in 2020, I met Paul on some of the work that we were trying to do. And during my fellowship, I was like, I'd love to do work locally, but the intent is to be able to scale this work nationally and globally. So we decided to incorporate common data models like OMOP and use our local precision medicine initiative, Johns Hopkins University PMAP, to go ahead and combine our data. This idea that, hey, why are we relying on a common data model is simple conceptually, because we'd love to use common data models so we could scale the work beyond Hopkins. And this is where locally we mapped our Johns Hopkins data here into the OMOP common data model. We built up a NICU data set. That's the use case that I know. That's the use case I understand on maternal child health. So we built up a OMOP common data set here, and we allowed our researchers to interact with this data set. So that was at the macro level. Let's bring data together. And part of our approach was, okay, we brought data together at the macro level, but let's go ahead and quantify patient specific metrics. This we were able to do with the neonatal sequential organ failure assessment, the nSOFA, and BIS. And what they end up being is they're tools for us to quantify how sick a baby is. What is the degree of organ dysfunction? And I like these because they're EMR compatible, and they let us measure things in real time at bedside based off things that the clinical team is doing. Here's a little more details on the nSOFA itself. So again, trying to ground everyone in terms of the work that we're doing and then show examples. So the nSOFA pictured here is Jim Nguyen. He's the developer of the nSOFA and a close mentor as well. The nSOFA looks at organ dysfunction, how sick a baby is in 3 domains. There's the respiratory domain, where the score runs from 0 to 8, the cardiovascular domain, 0 to 4, and the hematologic domain, 0 to 3. And within these, high scores are directly related to more organ dysfunction. We're looking at the SpO to FiO2 ratio when intubated. We're looking at the amount of vasoactives prescribed, the amount of systemic steroids for blood pressure support, and then the hematologic platelets, where the degree of thrombocytopenia is correlated with severity of illness. And you're like, this is great, but this is not applicable to me. And that's okay, because our intent was to use this EMR compatible tool just to show that this type of work can be done. It can be incorporated. And if you're an endocrinologist, it might be more important to track A1C or continuous glucose monitoring data. As a pulmonologist, you might be more interested in PFTs or asthma medications. As a nephrologist, it might be blood pressure or antihypertensives. The point of showing this is we need something to go ahead and measure things at a patient level, which is scalable and quantifiable. And then part of our thinking early on in terms of research vision was that if we could standardize data at the macro, quantify severity of illness at the patient level, I think we'll be able to change the research paradigm. We'll be able to define things at scale. We'll end up with improved subgrouping and subtyping of our patients by disease, by organ dysfunction, with the ultimate hope that it's going to result in early identification within these subgroups. We could measure response to treatment. We could develop more targeted treatments. So this is how we were thinking right at the outset when we decided to build upon our work. Now, again, in 2017, when I started at Hopkins and proposed this as my fellowship project, this felt a little overambitious. It felt as if you submit a lot of grants, you realize that this might be too ambitious, not within the scope of a grant application. And now with machine learning, which sometimes people call AI at times, artificial intelligence, I think these things are within our grasp. The things that felt overambitious in 2017 now have entered mainstream media and mainstream healthcare, where people understand that some of the work that we're proposing and we're trying to do is actually doable because technology has progressed so much. And here I have a visual because ultimately this is what we're trying to do in our work. This is what we do on the clinical side. This is what I do as a neonatologist often, is we think in probabilities, right? We want to make sure our patient is doing well. So you could have probability of outcome X here on the y-axis. You have time here on the x-axis. You have this baseline probability, this pre-test probability for a specific disease. It could be your site level risk. It could be your unit level risk. It could be, hey, this is the baseline population Baltimore. This is the baseline population at Hopkins. This is the baseline population in Canada, whatever it be. Just establish a baseline. And then how is my patient deviating from that baseline in real time? And if we can feed high quality, reliable data into these models that we're building, that gut intuition that we have that my patient isn't doing well, we can quantify it in real time. We could share this information with others. It could be part of a next clinical trial. It could be part of the next research project we're doing. And then ultimately, we're doing this work to take better care of our patients, so then it could be part of that clinical team. So what does it look like in practice, right? This is an example of some of the work we did in extremely premature, extremely low birth weight infants. So these are babies who are born at less than 29 weeks, at less than 1,000 grams, so 2.2 pounds. These are babies the size of my hand, give or take. And I have very small hands, size 7 gloves. So in the babies, in this tiny high-risk population, we said, if we can measure organ dysfunction relative to time, so nSOFA here on the y-axis, time here on the x-axis, we're like, can we identify babies who will survive versus non-survivors? And we see that you could easily differentiate these babies very early on. And within the first 12 hours of life, we can identify survivors from non-survivors. Like, this is an important research project, but what does it look like? So are there other applications? Because in these tiny babies, survival is limited at times, and that's a function of how sick they are. And sometimes, despite our best interventions, that we're unable to help with survival. So we're like, let's continue to explore other areas, other disease states, other disease processes. One was related to, okay, because this is what parents care about. Not only will their baby survive, but will their baby have any, be at risk for severe neurodevelopmental impairment? So SIVH, severe intraventricular hemorrhage, this is bleeding in the brain. And then no IVH, you don't have any bleeding in the brain. So we looked, again, organ dysfunction relative to time, and this time the axis and the time scales changed. Instead of weeks, now we're into hours of life. And within the first 24 hours, these kids start to differentiate. And within the first 48 hours, this is the difference is widest. And this actually is exciting to see because this mimics biology, where babies are at highest, these premature babies are at highest risk for bleeding in the first 48 hours of life. And having this information that we're getting from just routine clinical data mimic biology is something that was exciting to our group and our work. And we're like, let's keep exploring this because, okay, we can't really impact mortality too much. We can't really impact SIVH too much. Let's go ahead and look at bronchopulmonary dysplasia. This is lung disease of prematurity, BPD. And we're like, what do parents care about? What do families care about? What do case managers, social workers who are trying to set up support for our kids who get discharged home from the NICU care about? And they care about, hey, did the baby go home on oxygen? Right? Did you have BPD, and was the BPD, your lung disease, bad enough for you to go on home on oxygen? Versus, hey, you have these same babies, same population that is not discharged home on oxygen. So no BPD. And we see that in the first week of life, we could start identifying them. And this trend continues where in the clinical setting, you're like, yes, sick babies go home with oxygen. That's not revealing. That's not news. That's nothing new to us. But if you can identify them early and set up supports early, then that's actually changing something that we could do to potentially better care for our families. The other thing about BPD that is unique, bronchopulmonary dysplasia, you're not born with bronchopulmonary dysplasia. It is a disease that develops over time. It's a disease that develops while you're in the NICU, while you're with us for the first couple of weeks of life, while you're in the NICU for 60, 80, 100 days. And the different ways we try to treat BPD, prevent BPD, is by providing surfactant, by providing steroids, by doing diuretics, by doing fluid restriction, PDA management. So all of these things that we're doing in the hospital to prevent BPD. So all of these modifiable levers that we're trying to pull on to make sure you don't develop disease or you have disease that is not as significant as other patients. Like, this is a disease that we should potentially study. This is something that we could actually intervene on and we can act on. So it might be worthwhile. Here, we said, all right, this is where our lab and our work started to go. Okay, we did the early informatics work of getting the data. Let's go ahead and put descriptive work together. These were the examples here. Now let's go ahead and do work which actually leverages AI, ML, and we put together this Sankey diagram, which shows organ dysfunction trajectories mapped to BPD outcomes at discharge. No BPD, mild, moderate, severe. This diagram illustrates how organ dysfunction evolves over 4 time points: day 1, 7, 14, 28 days after birth. And using symbolic aggregate approximation, SACS terms, you see how these trajectories correspond to the ultimate outcome of no BPD, mild, moderate, severe. And the width of each stream here represents how many infants follow a given trajectory. What becomes clear is that early organ dysfunction, if you have it, is going to map to severe BPD. And if you have no organ dysfunction, it starts to map to no BPD. And this is similar to what we see in genetics, where trinucleotide repeat expansions for Huntington's disease reliably predict disease severity and onset. So here we're using an EMR-compatible tool, nSOFA, to give us signatures to help identify early predictors of chronic lung disease. And the implication, hopefully, is that by recognizing these early trajectories, we hopefully are able to tailor therapies earlier in the NICU and design precision-oriented clinical trials that intervene before severe disease develops. And our next steps included evaluating how surfactant works, how different interventions work when we're giving blood products, the outcomes of tracheostomy. Hey, who are the kids who go home with medical technology? Like, who's going home with oxygen? And we're like, this is interesting, but to date right now, I should have disclosed this earlier. I have a lot of mentors. They are voices in my head, and these voices in my head tell me, hey, to date, you're just showing us correlations and associations. We really care about mechanism of disease. We really care about, hey, what you're showing with the EHR data that you pulled, does it actually make sense? And we're like, let's put this to the test. So here I've highlighted Dr. Alvaro Morera. He's one of our collaborators out in Texas. And I was like, Dr. Morera, we have this high output clinical phenotyping. Can we actually use it? Does it work with models? So he's like, I'm seeing some of the same things he started seeing some of the same things I was seeing. So if we can combine this high output clinical phenotyping along with BPD endotypes, we can potentially go after mechanisms of disease. In his work, he was seeing that there's 4 endotypes of disease, endotype A, B, C, D. And we're like, oh, this is nice because I have 4 phenotypes, no BPD, mild, moderate, severe. He's like, okay, that's cool. And then in terms of gene expression, we saw that in terms of unsupervised hierarchical clustering within a data set of 62 babies, we're like, there's high gene expression, low gene expression for some of them, where blue denotes low gene expression and red represents high gene expression. We're like, this is interesting. So we're starting to see these genes that have high or low expression. What does it mean? What does this resemble? And BPD, neonatal lung disease, is something that goes on potentially to turn into asthma, a common disease that is applicable to all children. It's applicable to adults who potentially may go on to develop COPD or other diseases. We're like, okay, let's go ahead and design an experiment around this. So here we said, because the first hypothesis we decided to test, hey, because asthma is pretty common, is asthma in itself associated with BPD? So we looked at the 10 gene signature, and the 10 gene signature is part of Th2 cells and eosinophilic inflammation. So in this phase 1, this transcriptomic asthma signature and about 111 VLBW neonates, so these are tiny babies again, over the first month of life, we saw, yes, this 10 gene asthma signature is associated with BPD. So that's the first hypothesis we tested. And next stage, we're like, in this human validation study, a cohort of 311 babies out of Texas, we're like, hey, this eosinophil count, associated with asthma, associated with atypy, does this eosinophil count actually provide us any information? And again, we saw that, yes, the eosinophil count is related to BPD. Then we're like, wait a minute, we didn't trust this 10 gene signature on this outset. So let's go ahead and take multiple transcriptomic data sets to confirm that the 10 gene signature ends up showing up in those populations too. Because this sample up here was from Krakow, Poland. We're like, does it actually apply to other data sets, other genetic signatures? And it did. And we're like, that's nice. We've shown that, okay, eosinophil counts work, transcriptomic data from different countries, different data sets works. Does it actually follow an animal model? So then in a baboon model of premature baboons who were born at 25 to 27 weeks, who were ventilated, we looked at the gene signature again for Th2 and eosinophilic inflammatory pathways. And in this 3-phase design of human discovery, human validation, animal models, it let us connect some of our bedside observations to biology in a pretty rigorous way. I'm like, okay, this is nice. And the major things that we saw there, to bring it home, is that patients diagnosed with BPD severity consistently exhibit higher Z-scores for Th2 inflammation as determined by our 10 gene signature over the first month of life compared to those without BPD. That's this panel A that you're seeing. In this panel B, the Th2 inflammation Z-scores are stratified by BPD severity, and they show a significant difference between no BPD and severe BPD. And then in terms of this part C, like early disease, early neonatal disease is not associated with BPD later on. We didn't see that. And in terms of predicting BPD at day of life 5, this is again going, instead of using our nSOFA work or our routinely collected clinical data, we're like, if we just use our genetic data and our genomic data and work along that and the gene expression, we could predict BPD by day 5. And then in terms of the odds of developing BPD, that's panel E right here, based off high or low gene expression, the odds were about double. So now there's other baboon work that I'm not showing on the slide, but the animal model for BPD revealed like elevated plasma concentrations of IL-5, 6, along with increased gene expression. At this point, you might be like, why are you talking about premature baboons? I came to an informatics talk. You said you were going to talk about clinical data. And I'm sorry, but this was something that we needed to do for ourselves, our lab needed to do to go ahead and ground us that all this clinical informatics work that we're doing, all this data science work that we're doing, it actually is anchored in sound biological plausibility, gene signatures, mechanisms. And this puts me on cloud nine, right? Because, hey, what we're seeing clinically, we could tie in and design trials. So all of a sudden, this figure of our alluvial plot, Sankey diagram that's showing the different trajectories, clinical trajectories. Now, when I want to study impact of a drug, intervention, outcome, it's based in sound biology and mechanism. So now, not only can we do the clinical informatics work, we could do the basic science work, we could do true translational work. Here, I was like, let me go back from this surfactant project, let's bring it back. So pictured here is Simonsa. She's a graduate of our biomedical engineering and master's program here. Simonsa's thesis was on surfactant administration and response to therapy. So here we have our organ dysfunction. It's tiny, I think you're seeing in terms of the nSOFA score. Here, time, first 72 hours after birth. So 3 days after a tiny baby the size of my hand is born. We see those who received no surfactant in red, those who received one surfactant dose in blue, and those who received 2 or more surfactant doses in the first 72 hours of life. So this is what we saw in terms of all the data available to us at our Hopkins facilities. Then we're like, okay, these are the baseline characteristics of the groups. So setting that baseline. Now let's go ahead and evaluate an individual patient. So here, the dotted line represents one patient relative to the baseline. The baseline here is the 2 or more surfactant group. So you're a baby, a tiny baby who received 2 or more doses of surfactant. And you see this baby. This baby's trajectory is different. This baby's degree of organ dysfunction is different. So this baby's an outlier. This baby might be classified as a non-responder. So that was information that we're like, this is important. This could be important to the clinical team, the bedside team, or the next clinical trial we're trying to design around surfactant administration practices. And I'd love to, with the folks on the call later on, if you please email me. But as we move this clinical trial work forward, and if you're a clinical trialist, please email me because we're working together on putting this in right now. That was one aspect. All right, sticking with the respiratory theme, because I subjected you to baboon models and our genetic gene signature. We're like, these babies who are sick, what's their healthcare utilization? How often are they interacting with the healthcare system? What do things look like in terms of health equity? Access to healthcare when you're sent home with medical technology, such as a tracheostomy. So with one of our other PhD students, Jen Park here, we went through every type of healthcare encounter captured in EHRs, and then link them back to the type of visit. And for those on the call who do this work, you know it's not easy because even though you might be admitted to an inpatient unit, an ICU, right? At times, if you get a portable X-ray, based off of how that portable X-ray was ordered or how the X-ray technician decided to trigger the image itself, it might flow in on the back end of your data set as an outpatient visit, right? And we need to be able to understand this, these workflows, understand these mechanisms, and then roll them up to actually have something that is digestible, something that is usable for purposes of research, something that is usable for purposes of operations or clinical care. So with Jen and others, we said, okay, we were able to roll up our encounter types as inpatient, outpatient, procedures, emergency visits, home health, pharmacy. And these are the descriptions right here. And then we're like, okay, we did that part. That was pretty hard. And then let's go ahead and quantify the healthcare utilization. So orange represents patients with a tracheostomy. Blue are patients without a tracheostomy. And you see in the first year of life, our babies who we send home with a tracheostomy end up interacting with the healthcare system for 230 days in the first year of life. That's information I think a family would want to know. That's information a care team would want to know. Our social workers, our case managers would want to know, because this allows us to prepare a family and better care for a patient with medical technology. That's nice when we do it based off tracheostomy. We're like, can we actually do this for different disease states? Like, okay, let's remove the aspect of tracheostomy for a second. And let's look at what the impact prematurity has, bronchopulmonary dysplasia, infection or sepsis, congenital heart disease, retinopathy of prematurity. It's covered here, but SIVH, or you have a neurologic condition. And this is work again with Jen and Ben. Ben was a former postdoc, now here on faculty. We're like, if we can roll up these encounters and quantify healthcare utilization by disease, by intervention, by organism, that in itself would be helpful to not only our local healthcare system, but the national healthcare system. And this is where Ben, he's pretty much an OMOP guru at this point. He's developing a computable phenotype for tracheostomies, which is independent of age, site agnostic, EMR agnostic, and he's trying to assess the impact of healthcare policies by state and state level influences, state level resources, how they're going to impact healthcare utilization. And now this is, I think, important, because now we could do this for maternal health. We could do this. We have this hypothesis we're testing in our lab, which doesn't sound too obscure, is our pregnant persons, when they're sick, they might have more preterm labor, they might have more complications. Let's go ahead, and their babies might be sicker. And if the babies are sicker, that might impact maternal health, because parents care about their babies that are admitted to the NICU. And we're like, all right, another area of intervention is blood transfusions, right? I'm picking random examples using the same data to highlight not only the work of these BID students, but to show that this disparate data could be combined in one population and then used for multiple use cases. So here, Robert Barrett, also one of our PhD students, he was interested in transfusion in preterm infants. Up here are our transfusion guidelines locally. And these transfusion guidelines say, hey, these are the thresholds we use for when to give a baby blood, a tiny baby blood. The guidelines and some of the major papers that have been published in this space continue to say, we were unable to adjust for severity of illness. So please use your clinical judgment before you decide to transfuse. So with Robert, we decided to pull, okay, what does the hemoglobin value look like across gestational ages? And blue here shows not transfused, red here shows transfused. Here it's time. Y-axis is your median hemoglobin value. And we see that, hey, these tiny babies get transfused a lot based off hemoglobin values. So these thresholds that we're saying, there's a bunch of overlap here. And this bunch of overlap says that people are using their clinical judgment over and over again when deciding whether to transfuse or not. So these guidelines, are we actually using them? Or is it clinical judgment? And I'm glad we're using our clinical judgment and correlating things clinically. So now another way to look at this data was, hey, what if we look at the degree of organ dysfunction? It's not hard to believe that sick babies in the ICU, we end up drawing a lot of blood on them to go ahead and see what's going on, to check their gases, their lab values, their hemoglobins, send different tests because we're worried about them. Now, if we do it based off severity of illness, you're able to see that the two groups actually differentiate. Now, all of a sudden, those transfusion guidelines, which we weren't following too well because we were using our clinical judgment, we could use an EHR compatible tool for some decision making. Here, we're like, Jen and Robert, with their work, we're like, hey, what if we build a simple logistic regression model to assess based off severity of illness, based off hemoglobin, and what if we combine nSOFA and hemoglobin to see how you're transfusing babies and what actually works best? And it seems like if we take into account our clinical judgment along with hemoglobin values, aka our guidelines, we can actually see who's going to be transfused more, see the timing of transfusion, and do better risk stratification. And later on, you see like these weeks where people are getting transfused. That's because different neonatal complications might happen, such as surgery. So then you're getting pre-op transfusion or post-op transfusion. In other work, sepsis, right? What type of babies get a lot of blood? Sometimes if you have sepsis. So Star, who's one of our another BID student, PhD student, he's working with Dr. Harold Lehman and others in our program to identify what are some clinical prediction models and clinical decision-making tied to those models from a qualitative and quantitative way of looking at it. So in terms of sepsis, here for a single organism, Klebsiella, right? So taking a step back, most neonatal papers and papers in general about sepsis, they just usually say it's a binary variable. Did you have sepsis? Yes, no. But when you look at a single organism, Klebsiella, at times there are patients who know that are very sick with bacteremia or sepsis versus patients who are not as sick with bacteremia or sepsis. So here you're seeing each line here represents an individual patient, their organ dysfunction by growing the same organism. And you see the heterogeneity here in terms of patterns. So this is the first step Star was doing. Then he's like, when these babies have sepsis, you give them antibiotics and you hope they get better. Yes, that's usually what we do. But we know that pathogens are multifactorial. They're related to both the innate and adaptive immunity. So we might need better ways to quantify this work to see what we're doing, what we're not doing, so we could describe this better in the literature. Here, part of Star's work, he's like, how about we visualize it in a better way? Because if you're giving antibiotics and you're worried about sepsis, how about I put together organ dysfunction timeline for you, along with your clinical decision-making or your clinical practices of administering antibiotics. And you see here, in a patient who has no culture result, right? Their culture is negative. They're not growing an organism. We still continue antibiotics because they have high degree of organ dysfunction. And they're like, why are you giving antibiotics for someone who doesn't have anything that resulted as positive from their microbiology table? We're like, well, would you stop antibiotics if you were worried and the patient was getting sicker? And in ICU, sometimes we administer them because we're worried that not every pathogen can grow. There's this concept of culture negative sepsis. Some people believe in it, some people don't. But the bedside team says, I'm worried about this patient, and they usually administer antibiotics. So we're like, is this an opportunity for antibiotic stewardship? Where when should you continue antibiotics? When should you stop antibiotics? And I don't know the right answer there. This is something that's a little under research, but it's pretty easy to continue antibiotics when you have a high degree of organ dysfunction in an ICU. But conversely, again, part of antibiotic stewardship, clinical behaviors, when you have no organ dysfunction, flat line here, you have no pathogen which was isolated from their blood, what do? And here, Star's like, why is this patient on prolonged course of antibiotics rather than a routine rule out of 48 hours when there's no organ dysfunction? And this is where, again, working with our BID students, Brooke, who also a PhD student, ends up being it's nice that she's a PhD student and has a PharmD. She's like, I see that you're prescribed piperacillin and tazobactam, aka Zosyn. So she's like, you're probably treating neck, necrotizing enterocolitis, medical neck, for which we routinely give antibiotics. So she's like, and then by connecting Star with Brooke with Star, they're able to work through this issue together and correlate it clinically and tie back, oh, I was building a model about organ dysfunction. I was trying to do this. Hey, if you have too much organ dysfunction, it's okay to prescribe antibiotics for a longer duration. But here, when you have no organ dysfunction, why are you still on antibiotics? And you could go in circles while you're pulling the data or running the data. But by having a multidisciplinary team, we can talk to each other, talk through things and say, hey, this is actually not an error in your code. This is done correctly. This is still showing the use case, and it actually is applicable clinically. And part of Brooke's work, other area that she was looking at, she's like, I know we care about organ dysfunction. I know we care about severity of illness. So our tiny babies sometimes, when they have surgeries, when they have trouble breathing, we give them sedatives, we give them paralytics, we give them opioids to sedate them so the ventilator can do more work, or if they're having bedside surgery, we give them pain medicine. So we see in a, again, tiny cohort of babies the size of my hand, we looked at patients who had no opioid exposure, patients with opioid exposure. The kids who have opioid exposure usually have higher severity of illness, as measured by the VIS and nSOFA, degree of organ dysfunction. Then we looked at the milligrams of morphine equivalent here, the morphine milligram equivalents, the MME, excuse me. And we saw that tiny babies who have more organ dysfunction have more exposure. And some of the next work that should be coming out is going to be looking at the degree of morphine exposure in terms of morphine exposure controlled for gestational age and severity of illness to see the neurodevelopmental outcomes for these babies. And right now, you're like, you just went through blood, MME, like opioid exposure, sepsis, BPD, surfactant, medications. And I'm intentionally doing this to show that because things are EHR compatible, because we could measure things at a macro level and at a micro level, we could do a lot of cool work together. And one thing in this CMIO role that I'm learning and continue to do is what's the operational benefit? What is the benefit to our patients, our families? So why are we just limiting ourselves to just research? And I put just research in quotations because research is hard. So we're like, let's go ahead and integrate our organ dysfunction metric into the EHR. And it might be the nSOFA for us. It might be something else for you. It might be continuous glucose monitoring, PFTs, other aspects. But it's important to integrate these things within the medical record or to be able to mine it in an appropriate manner. Part of our integration looked like embedding the nSOFA into the patient list. This is where it is. When you hover over it, it lets you know organ dysfunction and what domains. It gives you a trend of the organ dysfunction relative to time over the last 48 hours, what things look like. And this is what it looks like in the flow sheets, showing the individual components. And I'll just say that if you ever get tasked with mining data, there's gold in the flow sheets, and flow sheets have a ton of information that we use daily. It wasn't good enough that we integrated nSOFA into our EHR. We wanted to make sure that if we're measuring severity of illness, let's do it with other universities, other centers. So this is a screenshot of the nSOFA integration at a different university, different center. And currently it's running in over 24 centers, EPIC and non-EPIC sites. So we can benchmark, not just within Hopkins, but nationally and globally. So we took this nSOFA work and this work in general of being able to quantify things at a local level, having good data. So our bronchopulmonary dysplasia team, neonatal lung disease, it's the only NICU complication that's increasing over time as we resuscitate smaller and smaller babies. And at JHH, our campus here, and Bayview Medical Center, the rate was about 50% in 2020. Based off good data, and the BPD team here, led by Dr. Macher and others, and part of this, we standardized practice, we did better subgrouping, we created awareness to reduce our local rate of bronchopulmonary dysplasia. And I think that's taking what we're doing from a research side, bringing back into clinical care, informing our clinical teams, and working with our clinical teams, this is able to be done. In terms of from a QI operations perspective, NICU bed in the state of Maryland, give or take, depending on which metrics you use, costs about $3,000 a day. Our goal was, hey, can we reduce the length of stay by 1 day for one of our admissions here? And right now, we've been able to do that over the last couple of years, where the savings to date are about $3.5 million and counting. And this is done by identifying patients who might need medical technology earlier, setting in the supports, working with case managers, working with social workers, so that long tail of your NICU stay, we could potentially, because we've identified things, and we could set up the home oxygen earlier. We can set up resources earlier. And if you can move those interventions a few days earlier, you can potentially get those patients home with their families sooner. And the other aspect of when you're reducing length of stay, the data aren't represented here, but we didn't have an increase in bounce backs or patients returning to the EHR, returning to the hospital. Now, that's what we've been doing for the last couple of years. I'd like to talk and switch gears right before I end in terms of future state direction. I don't think biomedical informatics talk these days is complete without some generative AI work, agentic AI work. So just the distinction in my mind and the definition that I like to use, generative AI is a content creator, agentic AI is a goal achiever. It takes the content and does something with it. So in terms of just some local things, I'm a big fan of Nigam Shah's Stanford group and Christopher Shu and our local group here in terms of what do we actually need for generative AI, agentic AI? We need data, and we need lots of it. These data need to be structured, curated, and clean. ChatGPT wasn't just trained on your local data. It was a diverse data set that was already cleaned, and the data was continuously pouring in. Two, I think we need math, all right, algorithms to make sense of the large amounts of data being ingested. And this is where, with folks in our BIDS program, such as Dr. Lehman, Dr. Karazi and others, we're able to talk through some of the algorithms, some of the math behind it, right? Anyone can run Python code, R code, but should we be using that algorithm? Should we be doing this, right? And that's important to know before we just go ahead and run a package. Compute, specifically high performance compute, right? Because we have billions of data points coming through with multiple if-then scenarios. They need to be processed at high speeds. I could tell you that all the PhD students that I showed you, they like things to run fast, and they get antsy when it's running or it's spinning. And if you're clinical, right, think how antsy you get when you're waiting for Epic to load up when you hit your launch screen. So compute is definitely important in this work. And then we need an incentive, right? For us here at Hopkins, it's our mission driven, right? We care about our patients, our families. We want to be leaders in the innovative research space that results in prevention and treatment of diseases. And then one of our big missions and incentives here is to train the next generation of leaders. All this data science work and technology that we're doing, we want to be able to share it. We want to be able to collaborate. We want our students to be teaching us. And I learned so much from the students that I have in our lab. Now, after you have those 4 prerequisites in place, right, it's also to ask yourself, any tool, anything that you're deploying, will it be useful? Is it actually impactful? These are the questions that I run through from a useful perspective. The first assumption we make is the model and the corresponding output is useful, reliable, and fair AI-guided care. There's many definitions of fair AI care. One approach we take is when the model output is similar to the population level data, the epidemiological data, because epidemiology is still important. And does it actually follow known biology or mechanism of disease? Is it in line with what the experts are saying, such as the folks on this call right now? So you have to answer yes to this first question. Assumption 2, do we have the policy and capacity to act? At what level of risk estimate are we going to do something? Is the risk 5 times higher, 10 times higher, 20 times higher? Is this a judgment call? What is our threshold to act? Okay. Can we do the thing that our model is saying we can do? For example, I showed the MME equivalent right now. And what if my model, and what if we bank a model that says, hey, because you're worried about brain injury, and before you give any dose of morphine, please go ahead and get an MRI for the baby every time to make sure there's no evidence of white matter injury. That's just not feasible or practical. So our model should be in line with the things that we can actually do and deliver. This is, there's some work in this space, again, out of the Stanford side with Nigam Shah and others. So you could actually do work here related to examining under your capacity constraints at a system level to see if you could do the specific intervention and follow the model output. Assumption 3, the properties of the intervention, right? Whatever the model's proposing, whatever your AI work, your agentic AI work, is proposing is the risk-benefit profile. The intervention needs to have more benefit than harm. And then ethical AI, this is all by itself on a slide right now, and this is the framework that we proposed in neonatology, is this needs to be a priority integration. This is at the outset before we even begin some of these projects when it relates to implementation, clinical decision support, and hooks. So we bring this in right away and make sure that we're doing this appropriately. And before we launch anything in our system, we take it to one of our AI subcouncils where we have multiple subcouncils running. And those subcouncils were a direct result of the Johns Hopkins Responsible AI Task Force, where the principles of AI use are highlighted here, and the AI implementation plan is here. And this AI implementation plan is where I spend a lot of my time, is in terms of our data readiness, our IT infrastructure, model governance, our policy compliance and transparency, and then most importantly, training and education. Because all the things that I presented today are a direct result of these pillars that we put forth. And anything that we implement into the EHR, anything that we do use for clinical care as part of this principles of AI use, which we actually do follow. Now, I'll end with that in the sense that, right, I displayed the task force, but I'd like to make a point to acknowledge these mentors that I have, because these mentors guide the work that we're doing. These mentors guide some of the decision-making of how to do the work. And these mentors are leaders, they're luminaries in the field that, like, if you're studying this disease, make sure you account for this. Or if you're implementing this into the EHR, make sure you take this into account. Hey, if you're about to display to a family that their child's at risk for dying, you better make sure that you're talking to them appropriately. And this is why we have ethicists on it, we have basic scientists on it, we have maternal fetal medicine on it, lung biologists, brain biologists, sepsis biologists, informatics folks. So they're here, and this is only a subset of the folks that we work with. I'd also like to acknowledge the clinical faculty or clinical care teams, because if we don't, as informaticians, we don't want to make tools just for the sake of making them, especially if they're not useful to the end user. And I also like to acknowledge the lab here, where the master's, PhD students, Odyssey community, this is a family, it's inclusive, it's collaborative. And part of the mission here is to train our students. So I'll end with that. Thank you. And here's a picture of one of our students, and go with the flow sheets, because everything's in the flow sheets. All right.
Khyzer, thank you so much for that really wonderful presentation. That was really exciting. There's one, I guess, clinical research question about how you handle culture-negative sepsis in the NICU around fungal infections, and how that might relate to the nSOFA score and the risk of continued antibiotics.
Yeah. So on the clinical side, so fungal infections are relatively rare. They're relatively hard to quantify. And in terms of the resulting lab value, it might take a lot of time. So I could tell you that fungal infections is a space that we're still looking at. And we see that there is a lot of organ dysfunction in the few kids who end up with fungal infection. Right now, our ends are too small to comment on it too appropriately. So we're still building our models on that.
Yeah, the other question was really interesting. So how did you standardize the conversion to the nSOFA model for all the other health systems? Because that usually involves the flow sheets and the smart data elements.
Yeah. So there, what we did is we did the hard work of not only defining our local flow sheets, but also saying, hey, these are some of the epic foundational tables that this information lives in. Because let's go ahead and give you not only the medications that are used to comprise the score and the structured data elements, so you can find them, but this is what a build would potentially look like. So sharing that information, that was key.
So you're able to share the actual like epic, I guess the templates or.
I think did Paul cut out for anybody else? So I'll say that as you reconnect, hopefully it's not me who cut out. Hmm. Stacy, is it Paul or me?
Yes, it's Paul. We can still hear you.
Okay, so we didn't share any Epic code itself because Epic customers, Epic clients, that's proprietary. So for that, what we did is we shared how we did the work and the flow sheet elements that we needed to mine and the data sources and the variables themselves. So then locally, each champion at their site was able to put those things together. And we made sure that we're partnering with local champions because we don't want to deploy things that people may not use. So the site needs to understand and be willing to use it and want to use it. So it was people intentionally adopting things. And then I see a question from Taxiarchus in terms of how long did it take for other institutions to do the same? I comment there, sometimes depending on an institution's motivation and the timing, it could be as little as a few weeks. Sometimes it took a better part of 6 to 12 months. And in terms of what's the use case at that local institution, because we wanted to partner with people. We wanted people to be champions there. And if it wasn't the nSOFA, we're like, what can we help incorporate for you? All right. And once they realize that we're trusted partners, we like to collaborate, we're not here to compete, we're not here to scoop anyone, people started doing it on their own. So that's one. And then is there a possibility to incorporate OMOP? Incorporate nSOFA into OMOP? Yes, so Ben Martin is working on it. We're trying to make it a standard, part of the standard vocabulary, either the nSOFA, the SOFA, or in any aspect that you'd like, where it is just a integer value without any units. So it's fairly straightforward, and Ben Martin is the one doing that for us. Okay. So in terms of compute infrastructure on-prem, or do you purchase Azure or AWS? So this is just related to exactly the question and the work that we're doing. We have a lot of compute infrastructure on-prem. We definitely do. And right now that's what we've been using. And then in terms of purchase Azure or AWS for some of the work that I stayed away from our NLP work and LLM work. For that, we are definitely purchasing more compute to do the work effectively. And it's a lot of cloud compute that we're going to use, that we've started using, and we're going to end up using more and more. Side. And let's see. So in terms of, I know we're at time. So Dr. Benson, I could go ahead and answer this offline if you like, but pretty much in terms of to harness the power of our EHR data and bridge from research to operations, what do you anticipate your biggest roadblock or challenge would be? So I anticipate the biggest roadblock or challenge is communication is a big aspect of the work we're doing. And from an operational perspective, it's why should the health system invest in this? Why should the health system do this? And thankfully, I happen to be part of an institution that's really focused on caring for patients, caring for our physicians, caring for our APPs, caring for our nursing, caring for our colleagues. Because if it's aligned with our mission, we're able to move things forward. And then persistence. A lot of times it's getting to the right meeting, the right workflow, and bringing that in.
I just want to thank everybody for attending Grand Rounds today, and we will hopefully see everybody next month. Thank you so much for attending, and thank you so much, Khyzer, for your talk.
Thank you. Bye.